إلى أن
بإذن
يصل
الله.
الألف الأول إن شاء الله.
نبدأ.
ونبدأ دكتور أشرف.
بإذن الله. طيب نبدأ لأنه وصلنا للألف الأول.
توكل على الله.
يلا.
بسم الله.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific session, and I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. I'm the Vice President of the Saudi Society for Family and Community Medicine. And I would like to welcome you here tonight in a very unique scientific gathering where we have the scientific event under the umbrella of the Gulf Society for Family Medicine and the Saudi Society for Family and Community Medicine. In fact, these societies have been integrated together today for the first time, just to disseminate the information and to upgrade our competency towards excellency in the management of our patients in total, and with a special focus on the patients with chronic kidney disease. So this is, ladies and gentlemen, this is a chronic kidney disease integrated program where we are going to connect the Gulf for the best interest of those patients with the chronic kidney disease. And in this contest, we are going to shed light on the management updates for the broader chronic kidney disease patient. And I would like to thank on your behalf our guest speakers who are going to enrich our scientific event with a lot of their expertise and thoughts. We have Dr. Anas Al-Yusuf from Kuwait, Dr. Sultan Al-Dalbahi from Saudi Arabia, and Dr. Khalid Mahmoud from Qatar. And I would like to extend my thanks also for Boehringer Ingelheim, for their sponsoring this scientific event. And a special thanks goes to the organizers, Fexus Company, ملتقى الخبرات لتنظيم المعارض والمؤتمرات. In fact, ladies and gentlemen, as we know in our region, not only the Kingdom of Saudi Arabia, there is a total transformation in our healthcare system. And now we have identified primary care with a special interest in primary care in family medicine to make the drive for the change that we would like to have optimization of our resources and the outcome that is desirable to enhance the health of our community and to move all the way to the new concept which we have adapted, which is a value-based healthcare. So in this program today, we are going to make ourselves competent enough to screen, to diagnose, to treat, and to refer patients with a chronic kidney disease. And as you know, that all the family physicians, they are the front liner. So our role to screen those patients at risk is very important for us to overcome the problems of having the complication of the chronic kidney disease, not to reach the end-stage renal disease and then ultimately to kidney transplant. And as you know, the chronic kidney disease is very prevalent among the GCC populations. And as you know, it's a leading cause for many comorbidities, and it's also associated with congestions with cardiovascular disease and diabetes. And that's why the early detections of the kidney failure facilitate the appropriate diagnosis and the treatment of CKD. And here comes the roles of primary care physicians to adapt this kind of concept of screening and diagnosis. And in spite of the current and updated guidelines for the chronic kidney disease, unfortunately, the chronic kidney disease is underdiagnosed in patients with diabetes, and the recommended CKD testing is underutilized. So this is the problem that we have and we are encountering in our day-to-day practice. So with the objective of this meeting is to highlight the landscape of chronic kidney disease, epidemiology, diagnosis, and to identify the unmet needs and the gap in managing those patients. So I hope that this session will be quite interesting and fruitful for all of you. And I would like to urge you, please, to put your questions in the Q&A box, so we will be able to have your questions available to our speakers to answer at the end of these sessions. As you know, this session is accredited by the Saudi Commission for Health and Specialty, and all of you who has been registered will be eligible to have these CMEs as long as they stay with us till the end of this session. So without any further ado, ladies and gentlemen, I would like to introduce our first guest speaker, Dr. Anas Al-Youssef, who's a consultant in internal medicine and nephrology, the head of the Nephrology and Dialysis Center at Al Amiri Hospital Faculty of Medicine in Kuwait, and the president of the Kuwait Nephrology Association. So he's going to show landscape and the epidemiology, diagnosis, and prognosis, and the gap of chronic kidney disease in the Gulf countries. So I think this is very important for us to know the basic of the problem, and we will be knowing exactly how to manage these problems with allocating all the resources and to put ourselves in the front lines to manage it as we go through the different perspectives of this meeting. So without any further ado, on your behalf, ladies and gentlemen, I would like to welcome Dr. Anas Al-Youssef. So Dr. Anas, the floor is yours.
Thank you, Dr. Ashraf. Assalamu alaikum. Good evening, everyone. Truly a pleasure to be part of this symposium with you tonight, and thank you very much for the invitation. It's probably my first collaboration with the Saudi Society, and I thank you for that very much. And actually, Dr. Ashraf, you covered almost all the objectives of my talk. A very nice introduction and summary as well. Allow me to share my screen.
Okay.
Can you see it? Yes.
Yes, we can see it. Yes.
Yeah, my talk would be about the epidemiology and diagnostic and prognostic gaps of chronic kidney disease in the Gulf countries. The first gap we have is we don't have a registry. At least in Kuwait, we don't have a registry for diabetes or for chronic kidney disease. We have our own data from dialysis patients where we know the numbers, the prevalence of some diseases, but unfortunately for CKD, we are working on getting a registry for that. There is one registry shared among the Gulf that is from, so this is my disclosures, one registry from the DOPS. DOPS is an international dialysis outcome among hemodialysis patients worldwide, and there is GCC DOPS where we have all the GCC countries participating in that study. It was I think it was 6 phases. Each phase is 3 years. So the Gulf were participating in the later stages, but it was mainly for hemodialysis. Now in Kuwait, we are starting to have CKD DOPS, the first among the Gulf, and hopefully we start enrolling and other countries in the Gulf as well to enroll their patients mainly to understand the CKD prevalence, the comorbidities, and the outcomes. So from the hemodialysis DOPS, this was a study published recently led by Dr. Saeed Al-Ghamdi from Saudi about the diabetes prevalence, treatment control, and outcomes among hemodialysis patients in the Gulf countries. So we can see that they had about 2,200 patients. This was between 2012-2018 analysis, all the GCC countries. And we can see that the characteristics of the patients, the diabetic patients, they were about 45 to 74% of hemodialysis patients in the Gulf. This is a huge number. Each dialysis unit in Kuwait, about 50-60% of the patients are known to have diabetes. That might not be the cause of their end-stage kidney disease, but it just show how prevalent the disease is in our countries. The insulin use was about 45 to 50%. And the median hemoglobin A1C, although not that accurate in dialysis patients, but it was about 6.1 to 7.5%. They have concluded, as we can see, between diabetic and non-diabetic patients, despite the relatively younger age, diabetic patients about 60 years old compared to the non-diabetic 46-year-old, that the death rate, as we can see, is more than 2.5 times the non-diabetic patients. So they concluded that diabetic patients have high comorbidity burden and mortality rates despite relatively young mean age in the GCC countries. We need to tackle that further. Why am I speaking about diabetes? Although we should speak about CKD, because diabetes, as I'm going to show you, is the #1 cause of CKD worldwide and in our region. And here we can see that the prevalence among these 6 years and adopts is about 70% in some countries like in Bahrain and Kuwait, Qatar and UAE, slightly less in Oman, and the lowest in Saudi Arabia. So in our region, we are loaded with prevalence of diabetes. CKD is a global health issue. There is more than 850 million patients with CKD stage 3 and above, so that's EGFR below 60 ml per minute worldwide. And the global incidence is over 90 million, and it is rising because the incidence of diabetes is rising and is expected to increase worldwide. So the prevalence is about 10 to 15%, depends on where we look at on the map. About 5 to 10 million people of CKD die each year. The CKD is expected to be the 5th leading cause of death worldwide by 2040. It was 11th and 19th a few years earlier, but now we are seeing more of cardiovascular death in our patients. That's why we need to tackle this, and hopefully with the newer medications, we can screen them earlier and treat them earlier. About 40% of type 2 diabetic patients are at risk of developing chronic kidney disease in their lifetime. So that's why we're commonly seeing the diabetic patients to have CKD worldwide. If we look at the risk factors, we have the genetic predisposition. Patients with family history of CKD are at risk of developing CKD. And then we have the other traditional factors: smoking, hypertension, obesity. All these, sorry, I'm not sure why the slides are moving fast, but all these factors play a major role in the initiation and the progression. And we can see that these factors, obesity, smoking, hypertension, diabetes, all these are modifiable and they are treatable factors. If we can tackle this issue, probably we can have less progression of CKD on the longer run. As I mentioned earlier, diabetes is the main cause of CKD, followed by hypertension. So that doesn't mean we should only focus on diabetic patients, because more than half of the causes are not related to diabetes. Now, heart and the kidneys are linked, and more recently, with the newer advancement of the management and therapies, we are seeing more of this link together. We can see that in type 2 diabetic patients, we can see that the first complications they have is cardiorenal. CKD about 36%, heart failure about 24%. So 60% of the first complications in diabetic patients are cardiorenal conditions. Oops. Sorry about that. I guess the problem because I'm joining from the iPad. I apologize. Okay. No. I'm sorry about that. I'm not sure what's happening.
Well, Dr. Alsi, you might need not to put it as a full screen, so you can go like this, even if you want.
Like this? Okay. Well, it's against advancing, so there's something wrong with when we reach this slide. I'm really sorry about that. Not sure what the issue is. I don't know if Dr. Ashraf, if you have my slides, can you share from your side?
Okay, we will ask the team, the technical team, Dr. Abdul Hafid, and the team, if you have the slides, so you can advance it remotely.
ثواني الآن نعيد البث من عندنا.
Okay, I'll stop
تمام.
sharing.
أخ عبد الرحمن، أخ عامر، نواصل البث من حيث ما انتهى الدكتور في السلايدات رجاء.
We should go to slide 11. Okay, so then the slide 8, please. Yes.
Yeah. Big screen. بالفضل.
You can enlarge it. Can you make it full screen?
It's clear now?
Yes, it's clear, but put it full screen.
Okay.
You cannot make it full screen?
إذا كان في مشكلة في الفول سكرين خلاص we'll go ahead like this. So in
Yes.
order to save.
طيب. Okay.
Okay. So as I mentioned earlier, diabetic patients, they're at risk, or the first complications they have is cardiorenal. Here we can see that heart failure and kidney function decline are interconnected complications. One often exacerbates the other. So on the left-hand side, we can see that heart failure is associated with significantly higher risk of incident CKD. The blue bars is higher than the patient in heart failure than patients without heart failure. On the right-hand side, we can see the opposite, that there are the incidence rates of heart failure are higher in those with CKD patients. So CKD patients have higher risk of developing heart failure compared to non-CKD patients. And same thing, similarly, patients with heart failure at higher risk of developing incident CKD. Next, please.
Wait.
Next.
Yes. So, no, previous one. Yes. So here we can see that the diabetic by itself have a higher risk of increased mortality, about 4%. If you have diabetes and albuminuria, you have higher risk of mortality. If you have diabetes and lower EGFR, you have even higher, 24% risk of mortality. But if you have both diabetes and full-blown diabetic kidney disease, that is low EGFR and albuminuria, the risk of increased mortality is 10 times more than compared to only diabetic patients. The risk goes higher as you have lower EGFR and albuminuria in diabetic patients. Next, please. The prevalence of CKD is increasing. We can see between 1990 to 2017, the orange and the light blue bars are bigger. The prevalence of CKD is increasing, and that is mainly due to increased prevalence of diabetes. Next, please. Here we can see that the predictors of fast CKD progression on the left-hand side, the accelerated progression is higher within 2 years in diabetic patients compared to non-diabetic patients, almost double. And on the right-hand side, you can see that regardless of diabetes status, there are independent predictors of fast CKD progression that included elevated systolic blood pressure, patients with heart failure, patients with history of ischemic stroke, smokers, elderly, and patients with dyslipidemia. Next, please. Proteinuria per se is an important marker. We use it as a surrogate marker. We use it as a diagnostic marker as well. Proteinuria by itself amplifies the already increased risk in CKD patients. Here we can see that in patients, regardless of the age, in age group of the 25, 50, 75 years, of patients, the higher the proteinuria is, the higher risk of incident CKD. And similarly, the higher, the lower the EGFR also is amplifying the risk of developing CKD. Next, please. Not only for CKD, for cardiovascular outcomes as well, the higher the proteinuria, we can see that it is associated with increased cardiovascular mortality and decrease of other cardiovascular disease like stroke, coronary artery disease, and heart failure. Next. Here, the EGFR, the lower the EGFR, it is associated with worse renal outcomes and worse cardiovascular outcomes. In diabetics, more than non-diabetics, but the lower EGFR is a poor prognosis, but more so in diabetics, as we can see, the lower the EGFR we go, the higher the adjusted hazard ratio with regards to both renal outcomes and all-cause mortality. Next. Similarly, for albuminuria, the higher the albuminuria, as I said, as a driver, as a marker, and a prognostic marker, the higher the albuminuria, the higher incidence of CKD progression in patients, more so in diabetics compared to non-diabetics. Next. Here, if we have a patient with diabetic disease, the worsening albuminuria is an indicator that this patient is probably not going to do well, and they are progressing faster towards end-stage kidney disease. Next. This slide kindly summarizes what I've just said. As we can see, the lower the EGFR, so below 60, the higher the albuminuria, more than 300, we have this red bar. And this indicates increased risk of cardiovascular death. This is from advanced study. Next. And this is the same outcome from a meta-analysis from 25 general population cohorts. The lower the EGFR, the higher albuminuria is the higher risk of, or the more associated with cardiovascular death. Next. CKD is a silent disease. If we don't look for it, you'll not find it. Initially, or at the earlier stages, there are no symptoms. Patient will not complain of loin pains, will not complain of any urinary abnormalities. So we do not expect to have any symptoms. And usually, even patients, when they get referred, they are surprised that they have no complaints. They're not complaining of anything. How come they have chronic kidney disease? So that's why we need to tackle and screen for patients earlier so we can implement therapy earlier. If we can detect the disease earlier, there is a higher chance that we can probably not only delay the progression, but maybe treat with the newer medications. There is hope that we can treat CKD. So that's why earlier detection is the better outcomes for patients, and also better outcomes for the healthcare system. Because when we have patients, more patients on dialysis, this is a high cost because this is a chronic therapy. So that's why the earlier detection, the better for both patients and for the healthcare system. Next. So this graph is classical from diabetic type 1 patients, usually, where we know when we have when they get diagnosed with type 1 diabetes. Here we can see the graph of the EGFR. The point I want to make here is if we can see that the EGFR is increasing initially, this is for the first 10, 15 years, and where the patients are having hyperfiltration because of the hyperglycemia. And if we follow the graph, we can see that the starting point, we're going to meet it somehow in the middle of the graph. And this EGFR is about 100, 120. But the difference is, at the middle of this graph, we probably lost about half or 50% of our nephron mass. Patients still having the same EGFR, which is normal EGFR, but because of that long period of hyperglycemia, they have lost nephron mass. And when we detect CKD, so after, again, 15, 20 years, when they start to have albuminuria, at that point, we usually detect the patients, and probably they have lost about 70% of the nephron mass. And we're just dealing with this remaining 30% that we try to preserve in order to prevent patients reaching end-stage kidney disease. So again, the message is the earlier we detect these patients, the earlier we treat diabetic patients, prevent this hyperglycemia, better for kidney outcomes. Next. So that's why we recommend screening. But screening shouldn't be a mass screening because it's not going to be cost effective. There are certain groups from the KDIGO. We know that diabetic patients, hypertensive patients, obese patients, patients with family history of chronic kidney disease, patients who are abusing non-steroidals for longer period, these patients are smokers, these patients who need screening for chronic kidney disease. And also those patients with chronic inflammatory states like lupus, for example, these patients also need to have the screening done. Next. So what do we do for screening? Basically, screening is simple. We just need a blood test and a urine test. A blood test to measure the serum creatinine, and by that, from that, we can measure the EGFR using the CKD EPI formula, which is the standard nowadays. And we need a urine test to measure the albumin excretion rate. We need both tests. One test is not enough, as I'm going to show you in the next few slides. But we need these two tests, the blood and the urine test. And if they are persistently, so if the EGFR persistently low for more than 3 months, and there is persistent albuminuria, at least in 2 readings within these 3 months, then we can diagnose CKD in these patients. Next, please. The importance of the early detection and screening is we need to make patients aware of their disease. Here we can see that from the primary care setting, this study, close to 10,000 patients, diabetic patients, we can see that about 85% of the patients were not or had the blood test to check for creatinine EGFR, but only half of the patients, only half of this cohort did have a urine test. And by that, we can miss diagnosing CKD. Here we can see that CKD were diagnosed in 50, were present in about 54% of this cohort. Only 6.5% were diagnosed and they know about it. 47% were missed. And that's mainly because we have missed either doing the blood test or the urine test. So CKD is heavily underdiagnosed, especially in diabetic patients. Next, please. Again, same thing, that despite the growing burden of CKD, patients are underdiagnosed. The awareness is less because still patients are waiting to have symptoms to go and check themselves. And we as physicians, we need to stress on patients to screen them, to have the blood and the urine test at least once a year so we can detect the disease earlier. Next, please. Here we can see on the left-hand side, the patients with prevalence of CKD, stages 1 to 3, which are the earlier stages and usually silent and patients are asymptomatic. We can see that these patients, do have CKD, but are they aware? Do they know they have CKD? On the right-hand side, you can see that they are not aware. The first 3 stages, stage 4 and 5, they are aware because probably they have symptoms. Probably now it is kind of late to diagnose these patients. We have no much room to treat patients, but maybe delay the progression. But we need to we need this again emphasize. We need earlier screening and increase the awareness of patients to go and have the screening. Next, please. So here, another similar studies that, again, in the primary care, about 80% of the patients had no urine test over 3 years, or close to 1 million population CKD patients. And the other study in the primary care, close to 250,000 patients, 94% did get the blood test, but only half had the urine test, which, again, will reduce the detection rate of CKD. On the right-hand side, we can see that some physicians think that the urine test should only be done to diabetics. But hypertensive patients, we should just satisfy with the blood test to measure the creatinine and eGFR. But that's not true. We need to do both the blood and the urine test for both patients and all patients at high risk. Next, please. This is the heat map. I'm sure that you have seen it somehow. This is where we stage CKD patients. So on the left-hand side, you can see that stages from 1 to 5, eGFR above 90 to below 15, where this is kind of end stage. On the right-hand side, they added albuminuria in the staging system. A1 is normal, A2 is moderately increased, which is what we used to call microalbuminuria. A3 is severely increased, what we used to call macroalbuminuria. Now here, this is similar to what I've just said. If we have patients with CKD stage 1 and 2, or eGFR above 60, which is considered normal, if you don't do the urine test, if you just assume that this patient have an eGFR of 65 or 75, that's normal. But if we don't do the urine test, probably if they have an A2 or A3, they have a high risk of progression towards end-stage kidney disease. And probably this patient will lose an opportunity to get earlier treatment, where we can save the kidneys by years and save them years away from dialysis. So that's the importance of doing both blood and the urine test. Next, please. Here, just about the CKD stages. And as we go into CKD stage 3, eGFR below 60, we start to have the complications of CKD, that is hyperkalemia, anemia, hypocalcemia, and so on. And also the higher complications risk, which is mainly cardiovascular diseases and heart failure as we reach the end-stage kidney disease. Next. This is just for referrals. We had made a protocol or guidelines in our primary care in Kuwait, just to help the physicians when should they refer to nephrology service. So in general, usually I tell all the primary care physicians, if you are in doubt, if you see a patient with CKD and you are not comfortable treating the patient, or at least diagnosing the patient, you can refer the patient. They shouldn't be shy to ask for help. But in general, as a rule, eGFR below 30, they should be seen by a nephrologist, because at that time, there's nothing much we can do but just to prepare the patients for renal replacement therapy in terms of dialysis or kidney transplantation. But the earlier stages, patients should be seen and treated in the primary care and referred when they have heavy proteinuria, where we, at least as nephrologists, we are making sure that they're on the right therapy, and this heavy proteinuria is not related to something other than diabetes. Next, please. Here we can see that in diabetic patients, they have increased risk of progression compared to non-diabetic patients, and decreased cardiovascular mortality. Next, please. The number one cause of death in CKD patients is cardiovascular disease, and that's why we don't see much of our CKD patients progressing towards dialysis. Dialysis patients, probably 10% of those of CKD stage 3, mainly because they die earlier because of cardiovascular disease. Next, please. Again, similarly, just that cardiovascular disease is the leading cause of death in CKD and dialysis patients. Next, please. And that's why usually, this slide will not show properly, the link between cardiac and renal patients, especially heart failure. As I mentioned earlier, as we go towards end stage or advanced CKD, there is more heart failure, less myocardial infarction, more heart failure, more arrhythmias in these patients. And usually the link between the heart failure and the kidneys, weak heart will lead to weak kidneys, and weak kidneys will lead to weak heart. If you have low ejection fraction, the pumping function is less, the blood supply reaching the kidneys is less, and this will affect the kidney function. Similarly, CKD patients have increased salt and water retention, and they have increased sympathetic drive, they have the uremic toxins. All these will affect the heart function, leading to heart failure. So it's a vicious circle. Between the heart and the kidneys, we need both organs to work together in order to have better outcomes for patients. Next, please. So this is similar to what I mentioned earlier, that heart failure and CKD are interlinked. Next, please. This is probably my last slide, that the early and multi-factor intervention is the best way to help protect patients by reducing the amplifying risks associated with interrelation, cardiovascular, renal, and metabolic conditions. We have these conditions together in most of our patients, and they are interlinked. One organ, if it is affected, will affect the other organ. Diabetic patients can lead patients to have CKD, can lead patients to have heart failure. We need to treat these patients as early as possible to reduce these amplifiable risk to have better cardiorenal outcomes. Next, please. So in summary, CKD is prevalent worldwide, affecting 10 to 15% of the adults. Diabetes and hypertension account for more than 2/3 of CKD causes. About 30 to 40% of type 2 diabetic patients are at risk of developing chronic kidney disease. CKD is a silent disease. Both blood and urine tests are needed to make the diagnosis. The lower the eGFR and the high albuminuria are associated with worse cardiovascular and renal outcomes. Early diagnosis of CKD is of paramount importance for preservation of kidney function and cardiovascular states. With that, I will conclude, and sorry about the technical issues. And I'll stay for the questions at the end of this session. Thank you.
Thank you so much, Dr. Anas, for this wonderful illustrated presentation. And I know issues always any it comes out of sudden, like in Alhamdulillah, it was a good presentation. So thank you so much. And now, ladies and gentlemen, we'll move now to the second speaker, Dr. Sultan Al-Dalbahi. He's a consultant nephrologist and the director of nephrology and kidney transplantation in Prince Sultan Military Medical City. And he's a chairman of the Scientific Council of Nephrology in the Saudi Commission for Health Specialty in the Kingdom of Saudi Arabia. And here we are going to have another perspective of an important part of our scientific event, which is the Empire Kidney, providing the care for the broader chronic kidney disease patient populations. So I would like to thank you, Dr. Sultan, for being with us here today. And I would like to leave.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ashraf, for this kind invitations, introductions, and thank you for the organizing committee for the invitation and the organization. I know Dr. Yusuf is covering
the screen.
Yeah. Okay.
Yes, it's full screen. Thank you.
Yeah, okay. So welcome everyone, and thank you for the invitation, and thank you for Dr. Anas for covering most of the things that I'm supposed to cover, and this is what will help me to run faster for my presentations, and it will be in connection to what have been mentioned and said. And as you know, all this is a very important entity, the CKD, and the diabetes and CKD as well, as we are nowadays celebrating the Kidney World Day, and one of the theme, the component of the theme is the treating the CKD and the new medication in the CKD, and this is a very, very important because In the world, the estimation number showed like 850 million people with CKD in any kind of the CKD, and it's a mortality issue. It's increasing the mortality 47%, and increasing in the hospitalization and the demand in the health care and resources as well. And as we in type 2 diabetes, because this is like 40% the cause of the CKD, and you can see in the blue, in the red, and in the orange, this is the different type of the CKD, from the protein, from the drop in the GFR less than 60, or proteinuria, or both. So as you can see, this is a more than 60% of the cases in type 2 diabetes. So this is a very common in type 2 diabetes, and it should be screened, and it should be treated if we look for stabilization of the disease and improving the outcome. So, in any patient diagnosed with type 2 diabetes in different entities, there is more than 20% have evidence of the CKD, like drop in the GFR or proteinuria. And as you can see in the in the left side, this is the criteria for diagnosing the CKD by decrease the GFR less than 60 ml per minute, or the proteinuria more than 30 milligram. And this is the heat map is designed to say, like, as proteinuria progress and the GFR declining more, the patient will go to the red zone, which is the high risk entities. And really, we want to catch the patient in the orange zone and yellow zone, if we could, and screening them and try to utilize the newly emerging drugs, which will slow their progression to the red zone or the high risk situations. This is showed that as the proteinuria progressed and the GFR decline more, the mortality will increase. It's tripling and quadrupling. It's almost 36-fold of the different kind of populations. And the kidney disease or end-stage renal disease, it's reached almost 22% as the GFR declining more and associating with the proteinuria more than 300 milligram per gram. And you can see in the CKD3, the morbidity and mortality, it's almost 4 times of the other populations or the type 2 diabetes without CKD. But when the patient reach stage 4 and 5, it reach almost 3 times of the stage 3. So the mortality will become higher, and it will be a main concern at that time. So the matter is the early diagnosis and screening, and starting treating this patient and putting the renal cardioprotective measures, which can help those patients. So the aim of treating that one is glycemia management by any kind of glycemia, anti-glycemia treatment, blood pressures by using the RAS blockade, which is well and very, very cornerstone treating CKD due to type 2 diabetes. The lipid management, very important. Then using the new drug, which is targeting the cardiovascular and the kidney perspective at the same time, and improving the outcome of the type 2 CKD entities. Treating diabetes, there is a room for comprehensive care and glycemia monitoring, lifestyle. This is very, very important. However, glycemia or glucose lowering agents become the first line of the treatment, in addition to the approach to or individualizing or personalizing the treatment to our patients. So you can see like the weight and smoking cessations, exercise and diet, very important, especially the salt cutting. But the SGLT2, the RAS blockade is coming very, very importantly, the first line of the treatment, and should be taken as a level of the evidence. ADA in 2023 standards recommending the screening earlier, starting the RAS blockade as early as we could, and optimizing the treatment by using the SGLT2 inhibitors as early as we could, above the 45 when the evidence is very, very optimal in those patients. However, the GLP-1 receptor agonist becoming now emerging, especially in the obese patients, especially for cardioprotective, an additional effect to what SGL2 doing in such patients. So this is just showing that SGL2 is working in type 2 CKD, diabetic kidney disease, and there is a huge role in heart failure and slowing the progression of the CKD as well. Different guidelines and entities and guidelines bodies in nephrology like KDIGO and diabetes and endocrine like the American Diabetic Associations and cardiology as well all agree in level 1A of starting SGL2 in any GFR above 20. So it's very, very recommended. And it's level 1A, which is ethically, we should discuss it with the patient and we should offer it as the drug is available in the pharmacy. So I think this is very, very ethical as the evidence is reaching this higher level of the evidence. Even the Heart Failure Society as well, including the SGL2 when treating that one, because one of the beauty of the SGL2 is reducing the hospitalization in CKD patient due to the heart failure events. So this is taking me all of these, evidence and literature gap and what's been emerging literatures. It comes from this huge landmark study. This is RCT. Well randomized, well designed, multi-centers. The bulk in the West North America. However, there is in the UK and some European countries and some in Asia. So this is reflecting that it's a good heterogeneity of the population. So and different ethnicity and races in that study. And will distribute and they randomize the patient to empagliflozin, which is a 10 milligram once daily, and the standard of care means like RAS blockade and using metformins or using whatever treatment of type 2 diabetes, and they try to look for the CKD parameters like the GFR decline, the creatinine jumping and the proteinuria as well. And then they look at the cardiovascular as secondary outcomes for the morbidity, mortality, and heart failure, and as well the all-cause hospitalization and all-cause mortality. So if you go down to which kind of patient included, they include any patient above 18, any patient with any evidence of CKD, and any patient with the GFR more than 45 with and proteinuria more than 200 milligram, or the GFR more than 20 to 45. So it's in kind of the moderate risk patient of this one, and they should be on RAS blockade for a while and not using the SGL2 currently. They are excluding all the high extremity or high risk patients or patient on dialysis and polycystic kidney disease, because there's some evidence that some SGL2 might enhance the cyst progressions and enlargement. Type 1 diabetes excluded because there is not much evidence and efficacy in that part. And when we talk later about the DKA risk and type 1, we should exclude those things till we have more data among the type 1 diabetes and efficacy and those safety in those patients. So if we put it in the heat map, it's allocated in that area. If we take the proteinuria, they are in high proteinuria, and we talk in the GFR, it's in the moderate to let's say severe stages. So we are taking the patient who is a high risk for progressions by definitions. There is another studies, they look for the patient who is having a low risk and trying to prevent them to progress to the high risk. So this is a moderate risk and the aim for preventing the progression to the high risk. So this is the outcome, how they design it. and they look to the kidney from one side as a primary and cardiovascular as a secondary. Then this study terminated earlier because the efficacy showed very nicely in short periods, like 2.5 years, and there is no much side effect. Among those 4,000 patients, just 150 patients have some experience like progressions and reaching the dialysis, which is a very small number, and compared to the control group or patient who is not in the SGL2. If we come to the cardiovascular death and cardiovascular hospitalization due to heart failure, there is a risk reductions by 28%, and the lovely things, the number need to treat is a 28. So you need very small numbers, very worthful, kind of risk reductions. And the beautiful things that you will not wait for years to have the effect. The effect will start earlier, maybe in 6 to 9 months. It will be showed very significantly in 1 year, and it will continue keep reducing the risk among the 2.5 years. And this is very, very significant. If you this risk reductions maybe like a 10% in 1.5 years, but it reach like 28% in the 2.5 years. This is very, very obvious. And I think if we keep this patient in that drug for a while, we might really see a lot of risk reduction as well on them. Regarding the kidney disease progression, it's almost like 29% reductions, and as well started very earlier, and it's keep going among the days. It was started like from 6 months, and it started to keep showing and keep maintaining the risk reductions. Among cardiovascular death, it's very obvious and started after 1.5 years. Regarding the all-cause hospitalization, especially the cardiovascular, the heart failure, very, very important. It's reduced the risk to be admitted to heart failure by 14%. The number need to treat is a 28 as well. Started very earlier, and this drug is very diuretics. It's clean the lung and the left ventricles from fluid, and we know it is SGL2 inhibitors, but it's covering even SGL1, 2, 3, 4, 5, and 6, and we know there's a receptor of 6 in the heart. So it's working hardly, to clean all the fluids from the body, and this is very obvious, very clinically. My clinic, most of my patients on empagliflozin, they came in the with the dry lung, and the fluid status is very, very, very controlled, and compared to the control group. This is just to what we are seeing, and all-cause mortality as well. It's reduced by almost 13%. Started very earlier, and it's very significant death reductions among the control groups. Now, this is a general speaking. Let us go to subgroups. So is it a diabetes matters? No. Even in non-diabetes patient, the effect is almost very comparable. If we come to the different degree of the GFR, the effect is very, very comparable. And if we come to the proteinuria, the effect is very clear in the severe group. So in the severe group, the effect is very excellent. And the different kind of the GFR, the degree is different. So it is a very anti-proteinuric agent if we take it like more specific. Regarding the age group, there is no much difference. So it's work nicely in less than 60 and even in elderly. Gender is not a matter. And even in different population, it's very effectively working and leading to the same risk reductions. The other question now, is it a matter of the CKD due to diabetes? It's very effective in diabetes, but in the glomerular disease as well, it's very effective as well. And now in the IgA nephropathy, it's very effective, and it comes to be like a first line of the treatment, and all of the IgA patients should be on this drug to help and risk reductions and slowing the progressions and reducing the risk of morbidity and mortality as well. And hypertension is very important. It's a very excellent antihypertensive drug with adjuvant effect with the others medication as well. Hemoglobin A1C is not a matter of this, and the prior cardiovascular disease is not a matter as well. And regarding the RAS inhibition utilizations, it should be there, and the effect is very obvious and very, very huge. Without RAS blockade, there is a lot of controversy of utilizing these drugs. Really, we need to inhibit and control the RAS system before utilizing the SGLT2. As we said, in hospitalization, it's very effective in all kind of proteinuria and GFR degree. There is some dripping of the GFR after utilizing. This is a very healthy. This is a very, very important features. Those who dip initially by, let's say, 5 ml per minute, they do very great in long term, and compared to those who didn't dip or the control group. So dropping the GFR after utilizing that one was concerned before, but now we take it as a positive, and it's a very, very excellent survival features. What is SGLT2 doing in the GFR? The GFR will be slowly declining, and will be compared to the red line, which is the chronic control group. They drop very, very sharply, and they will reach end stage kidney disease earlier than IMBA group. So there is a meta-analysis looking for the diabetes patient and non-diabetes patient as well, looking to the cardiovascular all-cause mortality and morbidity. So the effect we are seeing in diabetes, it's equal to those in non-diabetes patient, like chronic tubular interstitial nephritis, hypertensions, hypertensive nephropathies, and glomerulonephritis. In the IgA, it's very effective in those groups. There is IMBA kidney, credence, and DABA CKD. IgA was there like 12% of the patient, and the effect is very comparable to the diabetic kidney disease as well. This is another meta-analysis showed the same effect. It's very significant with the same risk reductions by almost 29 in FSGS and IgA as well, and in favor of utilizing the empagliflozins. And in different group like IgA in DABA CKD with the dapagliflozins, or IMBA kidney with empagliflozins, it's showing the same effect. And the more potent in the IMBA kidney, because they use different kind of the CKD, they use like moderate to severe patient in compared to the DABA populations. People, they concern the side effect. This is a diuretics. One of the things can happen, dehydrations with the volume depletions, but this is a very, very minor and not significant, and very, very equal to the control group who use any diuretics other than SGLT2. I'm advising my patient to take it at night, half tablet if they could, and drinking a lot of waters, if not a heart failure patient. And we never face like AKI due to the pre-renal and dehydrations. Hypoglycemia is a very, very minimum, and there is no much effect on the hemoglobin A1C. UTI, because we are shifting all the sugar in the urine, so genital infection can happen, but this is very small cases, very treatable. I'm doing urine screening like cultures and analysis, to say if there is any colonizations. If no, we can start it very early. If it happened, we stop the medication for a while using antibiotic, and we can resume the drug again. AKI is not much concern, and regarding the ketoacidosis is a very slightly like a 6 cases, it's like biochemical or functional DKA. When we stop the drug and give some small doses of insulin, the patient will be out of the ketoacidosis. It can cause lower limb, thrombosis, ischemia in some cases. And this is with the sub-analysis of the study, it happens in those high-risk peripheral vascular disease patient. And I think this is because of the shifting the fluid from the blood, and the plasma will be hyperviscous, then it will be more heavy and viscous, and this might be a hypothesis. We are not seeing that one much. We are giving EMBA to all of our CKD patients, and we never face any kind of the lower limb ischemia due to these issues. So discontinuation for a reason or a side effect, it's very comparable to the placebo group. So there is no much discontinuation in the trial due to the empagliflozin side effect. Now the time to the kidney failure by the baseline, as you can see, is not in that slide. In this slide, you can see like the time of reaching or delay the progression to end-stage kidney disease. It's very obvious when we use it earlier. This is hypothetically, and if we use it very like advanced cases, no much room we can help the patient. So if we started in that area, like 45 to like 50 GFR and very proteinuria patient, we will have some like 15 years, stability before the patient reach the dialysis. So this is a very helpful as we are running with low slot and huge demand in the dialysis and different sectors, and it become a very global issues. So this is very strategic intervention might help us, to overcome such issues. So this is just showing like if we started on a GFR of a 20, the progression or the delay to reach the dialysis very few. If we started very earlier, as we go up, we can give more years of good health and good cardio renal protective effect. So back to these studies, the Credence, SCORED, DABA, CKD, and EMBA kidney, and different kind of patients. All of these patients, like if we can see like DABA, CKD, the GFR in those patients from 25 to 75, the proteinuria, it's very wide range. If we come to the empagliflozin, it's more advanced patient in this trial, and the proteinuria is almost like 2 grams of the proteinuria. So it's very specialized type of population when we take it from the evidence point of view. Well, studies in a heart failure patient like DECLARE, TIME58, and CANVAS studies and EMBERG studies, when they look to the heart failure or reducing the cardiovascular risk in those patients, it becomes very obvious and very clear. This is in heart failure. Versailles, the DABA heart failure, the EMBOR reduced study using the empagliflozin in well-studied patient in like heart failure with ejection fractions of 40 and an appropriate or medical standard of care. So in all of these measures or meta-analysis in the 12 trials looking to the different view, the kidney disease progressions, it's very obvious in both diabetes and non-diabetes. So this is a very, very CKD drug rather than diabetes drug. And when we talk about the acute kidney injury or rising due to that dipping, it's very, very comparable to all of these, like in terms of diabetes and non-diabetes. So the risk is very minimum and it's not a huge, and it's not relevant to diabetes and non-diabetes as well. Regarding the cardiovascular death and heart failure, among all of these different designed studies, it showed the same effect, and the risk reduction is almost 21% risk reductions as a composite risk reductions. So in conclusion from this meta-analysis, SGLT2 is compared to the placebo, reducing the risk of kidney disease progression by 37, acute kidney injury by 23, cardiovascular death and hospitalizations by 23. This is very important. From the evidence view, anything's more than 15% risk reduction, it's a very, very worthwhile. And this value, it's increased when the total or number need to treat is like less than 30. This is very, very excellent drug to be utilized. So now from people advise how we could use that one, how we could utilize the SGLT2 in the practice, especially the empagliflozin from the EMPA-KIDNEY. So you need to select your patient nicely by assessment, GFR more than 20, proteinuria more than 200 milligram per gram, any patient with heart failure, patient ruling out any kind of side effect or contraindications like genital infections, DKAs, foot ulcers, immune suppressions. Then after that, you will start using that intervention, the SGLT2, educating the patient. SGLT2 is a sick day medication. So when the patient feels sick or fatigued or febrile or admitted to the hospital, we should stop the empagliflozins right away. After utilizing that one, we just see the GFR in terms of 1 week. Then after that, if the dipping is very acceptable and within the range, we just see the patient in 2 months and even longer than this. Glycemia and volume will not, the glycemia, it will not cause a lot in hemoglobin A1C reduction. So hemoglobin A1C is not a matter as a number or as a follow-up when we talk to that one. From the volume depletion risk, we stop all the other diuretics. We ask the patient to have a good volume status, and we just observe if there's any AKI rising in the creatinine to hold those medications, especially in the 3 days from startings. Elderly patient, they feel dizzy when they utilize it, especially the first 3 doses. We ask them at night, take good amount of fluids. If you feel more dizzy, stop those medications. In some cases, I hold the antihypertensive and I just give the EMPA. If the things pass nicely, I just resume the antihypertensive medication again. But I assess the volume status in every single clinic when the patient come to that clinic. When we should stop the SGLT2, we should continue till the GFR less than 20 or the patient started on dialysis. However, there is some studies now on utilizing the SGLT2 for cardiac preventions and in the dialysis patient. In the transplant, there is a huge studies now to utilize it after 6 months from the transplantation. So this is the last slide. To conclude, EMBA kidney trial, which is reflecting all the evidence ongoing for the SGLT2 efficacy and safety. It stopped earlier because it's more positive efficacy before reaching the targeted duration of that studies. It's compared the EMBA risk reduction to the placebo. It's a very effective from cardiovascular risk reductions by 28 and the GFR stability by almost 37. And the treatment, statistically significant risk reductions of the all hospital or all cause of hospitalization by 14%. When we come to the hospitalization due to heart failure, it is a more potent by almost 29% in compared to non-SGLT2 group. So overall, safe data are generally similar to the previous known safety profile of the empagliflozins, highly recommended to be utilized in the practice. It's a 1A evidence-based drug. We should utilize it when it's available and the patient is fitting the inclusions criteria. With this, I would like to thank the organizing committee and Dr. Ashraf, and thank you, everyone.
Thank you so much, Dr. Sultan, for this wonderful presentations highlighting the EMPA kidney. And now, because we are running a little bit short of time, we'll move to the third presentation, which is another interesting part, which is patient-based clinical cases. This will be delivered by our guest speaker, Dr. Khalid Mahmoud, who is a senior consultant of nephrology, dialysis, and transplantation at Hamad General Hospital in Qatar. He's a professor of internal medicine nephrology at Mansoura University in Egypt. So I hope this will be quite interesting for all of us, and it will put all the theoretical part that we have learned into the real world practice in terms of cases that we can appreciate. So I would just leave the floor for you, Dr. Khalid. Thank you. You are muted, Dr. Khalid. You are muted. Dr. Khalid, you are muted. You are muted. Yes. Okay.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Thank you, Dr. Ashraf, Mr. Chairman, for your kind and generous introduction. And also, I'd like to thank my colleagues, Dr. Anas and Dr. Sultan, for their elegant presentation. I really liked both of the presentations. Today, I would like to present a case of chronic kidney disease that we face almost day to day in our practice, either as a PCB or as a nephrologist, but mainly as a PCB because you will refer it later at certain situations that we would like to share later, based on the current updated evidence for the best management of chronic kidney disease. This is my disclosure. Here I would like to introduce this nice gentleman, Mr. Sami. He's our patient today. He is a 55-year-old busy professional who works long hours and travels frequently on business, which makes his life somehow challenging to maintain his healthy lifestyle. He has hypertension and hypercholesterolemia, for which he is currently treated with ramipril and atorvastatin. He also has a family history of cardiovascular disease. Despite his best efforts, he has not managed to lose any weight. His BMI is still 29. So, do we need to screen Mr. Sami for his CKD? We will know shortly. Our dear primary care physicians, actually, they are the first liners to combat the problem of CKD, which is mentioned before by my colleagues. It's a widespread disease. And for this mission to be accomplished, they have to identify those who have CKD among their pool of patients they review every day. So screening of those should be individualized, not mass screening. It should be individualized. This is based on the so far established risk factors for chronic kidney disease, which definitely those with diabetes, hypertension, have cardiovascular disease, obese, They have positive family history. They are tobacco users, age plus 60. And sure, this lipidemic patient, they are our target group to be screened. KDIGO guidelines actually define CKD as abnormalities of kidney structure and or function where there is a decrease in the estimated GFR of less than 60 ml per minute and or proteinuria of A2 to A3 on 2 successive occasions 90 days apart, 3 months apart between the 2 tests. It shouldn't be one test to be at one time, and we would say this is a chronic kidney disease. And also, as Dr. Anas stressed on, that both tests should be done together. It's not a single test to be satisfying the criteria. These guidelines actually outline criteria for diagnosis and risk stratification for the chronic kidney disease, which include both estimated GFR and the albuminuria values. And also this has been highlighted before by my colleagues that according to GFR, starting from G1 till G5, where GFR is less than 15, and according to the proteinuria, starting from A1, which is normal, up to A3, passing through A2, where proteinuria from albuminuria, to be more specific, from 30 to 300 milligram per gram. As it's shown here, the higher the proteinuria, specifically albuminuria, and the less the GFR, it means the more risk for progression of chronic kidney disease. So the aid of these two simple, readily available, and inexpensive tests available in every center, in every hospital, that the eGFR and the albumin-creatinine ratio in the urine, we can identify those individuals with CKD as early as possible, which is fundamental for catching these people before having more deterioration and more risk for other comorbidities. So after we have identified these patients at risk and underwent screening already for the estimated GFR and albuminuria, those who had negative results, actually they will be periodically evaluated on that with the same base, eGFR and urine albumin-creatinine ratio, while others who showed positive results, actually they should be classified and stratified for chronic kidney disease. For example, if we have a patient with GFR of 70 ml per minute, it means he is G2. And if he has urine albumin-creatinine ratio of more than 300 milligram per gram, it means he is A3. So we would classify this patient as he has chronic kidney disease class 2, A3 proteinuria. There is an online risk calculator that has been validated in more than 800,000 individuals from more than 35 countries worldwide. It uses 4 variables: age, sex, eGFR, urine albumin-creatinine ratio, and this actually to predict the 2 and 5 years probability of end-stage kidney disease and the need for renal replacement therapy for an individual with CKD stage starting from stage 3A till stage 5. After we have classified our high-risk patients after screening, now it is time to decide whom will be referred to the nephrology clinic for further follow-up. And as we can see here, those who has proteinuria A3 and chronic kidney disease G5 and G4, those would be referred for the nephrology for meticulous follow-up or further follow-up. And the rest actually would continue to be followed with primary care physicians on different time intervals according to their degree of proteinuria and degree of CKD, either annually, semi-annually, or thrice per week. I would like to take the chance to highlight that there are other reasons to refer for the nephrologist, other than what we have just mentioned. These reasons are acute kidney injury, progressive kidney disease, those who have with kidney disease, chronic kidney disease, with refractory hypertension on 4 or more agents for combating hypertension, persistent electrolytes abnormalities, especially serum potassium, sodium, calcium, phosphate, recurrent or extensive stone formation. He has history of hereditary kidney disease and signs of nephrotic syndrome. Those should be referred for the nephrology clinic without waiting. This slide had been shown by my dear colleague, Dr. Anas, but actually, as he mentioned, it's a very important slide where it shows the value of the two parameters that we are using for screening, which is albuminuria and estimated GFR, and their impact on the cardiovascular death. As we can see, the lower the GFR, the higher the proteinuria, actually the more increased risk for cardiovascular death. So now, are we doing enough for our chronic kidney disease patients? Are we satisfied with the current management protocols? Actually, for the last 20 years, all we have for renal protection is RAS inhibitors. According to this renal trial, as we can see, it had 16% relative risk reduction to end-stage kidney disease. And the IDENTITY trial, with the use of irbesartan, they reached up to 19% relative risk reduction. Okay, but RAS inhibitors still possess substantial risk for residual risk of chronic kidney disease progression. In the renal trial, it was almost 43%. In the IDENTITY trial, it was almost 32%. So are we happy with these fair results of the RAS inhibitors? And keeping in mind that RAS inhibitors are not tolerated by all of our patients. We have some patients developing hyperkalemia we cannot manage. Some patients, they have irritating cough. Some patients with acute kidney injury. And this means that there is a sector of patients that is denied from any renal protection against their CKD progression until we have any game changers. Actually, in the last few years, I would say, there was evolvement of the superstar class of medication, which is SGLT2 inhibitors class of medication. And the evolvement of this medication actually showed a lot of success. And as per the KDIGO 2022 clinical practice guidelines for diabetes management in CKD patients, actually they stated that SGLT2 inhibitors are now the first line of therapy in patients with eGFR of 20 ml per minute or more. Do we have evidence that SGLT2 inhibitors are a real game changers and decreases CKD progression? Actually, yes. And they are now, as I mentioned in the last slide, they are the first line of therapy according to the KDIGO guidelines for CKD and diabetes. But actually, these data and these recommendations came and based on the three major randomized trials, which are CREDENCE trial, which included patients with type 2 diabetes, CKD with GFR of 30 or more, and proteinuria of more than 300 milligram per gram. Then it came the DABA CKD with a slightly wider range of patients, included those with and without type 2 diabetes, with GFR of more than 25 ml per minute and proteinuria of more than 200 milligram per minute. Then the bigger screen, the bigger scope of patients that had been included, they have been included in this IMPA kidney trial, which included patients either diabetic or not diabetic, those with proteinuria, those without proteinuria, included also patients with GFR as low as 20 ml per minute. And actually, maybe this study led to the fact that KDIGO decreased the starting point of GFR from 25 in the previous KDIGO guidelines to 20 ml per minute GFR per hour. And the IMPA kidney, just to know, it has been terminated earlier due to the overwhelming good results. The delay in chronic kidney disease in the previous trial was mainly in diabetic patients. However, the overall SGLT2 inhibitors actually reduced the relative risk reduction of kidney disease progression irrespective of the diabetic status, as shown here in this slide. This is a very important slide, had been also shown with my colleagues, but because it's very important, actually still we have to stress on that we have a GFR dip, which is expected and beneficial actually at after 1 month from the initiation of the SGLT2 inhibitors, where there will be slow improvement and picking up of the GFR later on, and after which this blue line, which represents the SGLT2 inhibitors versus the gray line, which the placebo group, actually, if we will extend these two lines to meet the time scale here of the reaching end-stage kidney disease, actually, we can find that the placebo group would, the placebo group will reach end stage much earlier than those patients who are having SGLT2 inhibitors, which means that SGLT2 inhibitors actually are buying years and decreasing the time and decreasing the need for renal replacement therapy for longer duration. As we can see here also for this slide had been shown earlier that the start of GL2 inhibitors at a GFR of 20 ml per minute, you will have almost 2 years between those who have started and those who didn't start SGLT2 before starting renal replacement therapy. And the higher the value of the GFR you start with, actually the more years you are buying for your patient before he starts renal replacement therapy. So, what to do next with Mr. Sami? I know maybe you forgot his situation, so I would remind you with his story. He is a 55 years old gentleman with hypertension dyslipidemia, which means he is a high risk for CKD and he should be screened. The primary care physician kindly requested eGFR and urine album creatinine ratio for him. The eGFR have been shown to be 68, which means he is G2. And urine album creatinine ratio was 40 milligram per gram. It means he's A2. So now he is G2, A2 CKD patient. And according to the online calculation that I have shown earlier for calculating the risk of developing in the stage, actually, he had a very low risk of developing in the stage kidney disease of 0.15%. And as per the KDIGO guideline heat map, Sami doesn't need to be referred for a nephrologist. And he is better to continue with his primary care physician and to be monitored on annual basis. Now the primary care physician and Sami should have a discussion about the initiation of GL2 inhibitor agent to reduce his CKD progression and to protect his kidneys and his heart from other progressive events of the chronic kidney disease and impact of chronic kidney disease on the longer term. In case of Mr. Sami, actually reducing the cardiorenal and metabolic complications should be at the top of our priority list. And to achieve these goals, we have to have a clear shared decision session with Mr. Sami to optimize his adherence to the treatment suggested. We have some common questions are asked by Mr. Sami and others actually. Usually you will be asked, how will the treatment will impact my day-to-day life? I would hate to end up with needing dialysis. I work for long hours, so I need a medication that is easy to take. Actually, all these concerns should be addressed carefully with Mr. Sami before he leaves the clinic. Do we have evidence for Mr. Sami if he was to develop type 2 diabetes or cardiovascular disease that SGLT2 inhibitors will protect him? Actually, empagliflozin showed kidney benefit in people with chronic kidney disease, regardless of their cardiovascular situation and diabetes status, where EMBA actually reduced the relative risk by 28% in people with and without prior cardiovascular disease. And also it reduced the relative risk by 36 and 18% in people with and without diabetes, respectively. What about safety profile? I think Dr. Sultan has clearly showed that in the big three trials, Credence, DABA, EMBA, rates of acute kidney injury, amputations, ketoacidosis, where are the most serious situations, are quite low in those patients. And for the sake of the cardiorenal and metabolic protection in type 2 diabetes, currently major guidelines are recommending the use of SGLT2 inhibitors, like American Heart Association, American Diabetic Association, KDIGO, and other bodies. This is my last slide. Finally, before Mr. Sami leaves the clinic, we have to highlight the following points with him. That people with CKD are at increased risk of heart failure, cardiovascular events, and mortality. SGLT2 inhibitors have been shown now to improve the kidney outcome, reduce risk of cardiovascular, heart failure, kidney complication, and it enjoys a high safety profile. SGLT2 inhibitors are now considered the standard of care first-line treatment option for people with chronic kidney disease and type 2 diabetes. Thank you very much.
Thank you so much, Dr. Khalid, for your wonderful presentations that highlighted a case study that covers the whole subject in very elegantly. Thank you so much. And now, ladies and gentlemen, we would like to start our Q&A sessions. So I would like to invite all the guest speakers to be available. So in fact, we have received some of the questions from the audience. One of the questions is, which degree of proteinuria preferred to start SGLT2 inhibitors? Dr. Sultan? Anyone?
Well, yeah, this is very important questions. Actually, as we say, like all the degree is very effective, like from the low degree and to high degree. It's anti-proteinuric agents. Most of the cases in the study, severe proteinuria, but I personally suggest starting in moderate kind of proteinuria, or start even earlier when we screen a diabetic kidney disease and found some level of the proteinuria, especially if the proteinuria associated with low GFR. So as early as we could, most of the evidence based on the severe proteinuria.
Okay, so how about the risk of diabetic ketoacidosis and the risk of lower limb amputation by using SGLT2 in patients with diabetes and chronic kidney disease? Is this concern still existing in the real world practice?
Well, this is initially, before the drug come up and people, they know the drug very well, it wasn't a huge emerging issues. Then after, people, they learn about, the drug and utilizing of the drug and avoiding anything might increase the risk of like amputations. For example, the Lasix or the highly peripheral vascular disease patient, risky patient. We are not seeing any patient like this. The previous incredence trial, or say on canvas and canagliflozin, there's some cases, but in real world data, we are not seeing those cases. But the hypothesis say that it's a lot of dehydrations and volume contractions might cause plasma hyperphosphaticity and might increase the risk of the thrombosis and lower limb ischemia. From DKA, actually, it is a very functional, very easy treatable, and we are not using much type 1 diabetes. We are not seeing much patient. I saw them like just by the laboratory. But when we start like the insulin infusions or even some injection of the insulin, the patient doing very great and become very out of that decay. It's very mild, it's not a common, and very treatable. And now there is a protocol to deal with such things as well. So it's not a concern preventing us from utilizing this important drug.
Okay, thank you so much. Dr. Anas with us. Okay, I think Dr. Anas is not with us now. Dr. Khalid.
Sorry, I'm there.
Oh, Dr. Anas. There is a question. Can we start SGLT2 inhibitors while we are approaching Ramadan, and there is a fear of volume depletion in Ramadan because we are a hot country? So, what is your recommendations? This is a question for from the primary care physician who have this kind of concern. So,
well, it's a great question. So, ideally, in other situations apart from Ramadan, when I started, am I afraid patient will be volume depleted? Usually not, unless the patient is on big dose of diuretics. Then I'll be cautious, maybe reduce the dose of diuretics and then start it. But now in Ramadan, if starting it, I would be cautious as well. Waiting for 1 month shouldn't be of a major concern. We know that the SGLT2 inhibitors will take at least maybe 3 to 6 months to start. So I would delay it till after Ramadan.
Okay. Thank you so much. Dr. Khalid, thank you for the presentation that you have highlighted the case, but I think one of the concern of primary care physician, they would like to ask about what is the profile of patients who comes to primary care with early signs or early symptomatology of chronic kidney disease. So how do you describe this kind of profile presentation to the primary care? And what stages of chronic kidney disease we can manage perfectly and safely and when to refer the patient to the nephrologist?
Great question. Actually, as has been highlighted earlier, I think by Dr. Sultan, that CKD is a silent disease. Usually you discover it accidentally. The patient's coming for somewhat reason, and you just check GFR or urine, and you can just discover that he has some degree of albuminuria or GFR is coming down a little. And then you start to dig more about his history. He's hypertensive, he has cardiac history and other situation. And then you will put the whole pieces of the puzzle together and you would say, okay, this looks, he is a high risk patient and he needs full screen and he needs follow up if he came positive for the screen, as we mentioned, with the two parameters, urine and blood pressure. The same heat map, I think we have just shared, that usually our dear colleagues, primary care physicians, they are the frontliners. Actually, they have the most of the job done by them before the patient comes to us currently. That's what we can feel in the clinics. Most of the patients are truly managed well before they progress to, as we mentioned, GFR below 30, or proteinuria more than 300, urine albumin creatinine more than 300. This is the limit that usually it is referred to us. And whenever he is referred, most situation, we will find him, actually he is in optimum treatment. Already they started the agent, SGLT2 inhibitor, they started already, he has been already on RAS inhibitor. So actually he should be sent to us after clearing these issues and identifying that his scale or grade of chronic kidney disease, he had G4, G5, or I mean GFR below 30 and proteinuria, albuminuria more than 300, then they can refer, but better to be referred that already he is on ACE inhibitor or ARB inhibitor plus DABA or IMBA or whatever SGLT2 inhibitor agent.
Okay, thank you so much. Dr. Anas, regarding, we are talking about diabetes and chronic kidney disease, but how about the pre-diabetes, which is an early onset of diabetes, which usually take place about 4 to 5 years or even 7 years before the full-blown pictures of diabetes. And there is certain evidence showed that also pre-diabetes is associated with a cardiovascular mortality, morbidities, and even in the stage of chronic kidney disease. So can we treat pre-diabetes the way we treat diabetes with chronic kidney disease, with the same modality of treatment?
Well, if we're talking about using the SGLT2 inhibitors, it's
Yes.
going to be an off-label if we're just targeting patients, CKD patients without proteinuria. So if I have, for example, hypertensive patients with proteinuria or history of heart failure or history of cardiovascular disease, then I have an indication to use these agents. But just a CKD without proteinuria, I'm not sure if we're gonna have any gain. MPEG Kidney showed that in those patients with lower albuminuria, maybe because the trial was short, but it didn't show any significant impact. So up to my knowledge, it's going to be an off-label use for this patient. Currently, I work like, I try to hunt for any cause to start these agents. So if there's a history of heart failure or proteinuria, despite being on RAS inhibition, I would add an SGLT2 inhibitor. But without proteinuria, I don't think I have a solid justification.
Thank you so much. Dr. Sultan, the combination of finerenone with the SGLT2 inhibitors, what are the benefits? Could these two combinations can be taken place?
Yeah, very excellent questions, because this is what we call it, the powerful tools to slow the progressions. I know SGLT2 is getting some risk reductions, but there is a residual risk in some certain patient, especially the patient with EFTA, if biopsy done for any reason, it's more fibrosis, they progress even with the optimal standard of care given by SGLT2 or RAS blockade. So finerenone, it's recommended for such patients, and those kind of medications, it's very safely to be used with or without SGLT2. We want to start RAS blockade, then SGLT2, then finerenone, in terms of triaging the patient nicely and avoiding any safety issues. But there is a confidence trial which is using the combinations of the SGLT2 and finerenone in the same times, and it's very efficient, and the safety profile is very excellent. And this is will prove that if the patient is a high risk for progression, we can use it in the same time, and we shouldn't wait. But it's very safe. However, the hyperkalemia associated with finerenone can be treated by the SGLT2, so it's a good combination. And yeah, it's a tool.
Okay, thank you, Dr. Sultan. Well said. And I think before we close, because this is there is in fact many questions, but because of the sake of the time, I would like to ask each one of you as a speakers to say one single statement that can drive the primary care physician to do the best for screening, treatment, and referral of patients. So if you would like to say it, Dr. Anas, Dr. Sultan, Dr. Khalid, one statement as a recommendation from your side to the primary care physician to take it in their practical considerations.
Any high-risk patient should be screened.
Okay. Dr. Sultan, you are muted. Yes.
Yeah, just for the primary care physician, or let's say the primary care nephrologist, they are the cornerstone in treating such patients. They are the frontliners. And I think initiating those medication by them, it will make a lot of effect rather than waiting for those patients to reach the specialized clinic care.
Thank you so much. Dr. Anas?
I would say 30-year-old dialysis patient has a mortality risk equivalent to an 80-year-old patient in the general population. So a patient really sick, we should try to prevent end-stage kidney disease.
Excellent. Okay, so coming to the end of this session, I would like to say some of the words that will be taken as a home message for my colleagues in primary care and all the audience who have been with us here for the past 2 hours. That chronic kidney disease is a prevalent worldwide, with a special prevalence in the kingdom of Saudi Arabia and all the Gulf countries, in fact. And there is an association between diabetes and hypertension, which account for more than 2/3 of the chronic kidney disease. And we know that these two clinical entities with sits as on the top of the priority and the top of the prevalence of all the chronic disease in the GCC. Chronic kidney disease is a silent disease, as it was said by our colleagues, and both blood and urine tests are needed to make the diagnosis. Low EGFR and high albuminuria are associated with a worse cardiovascular and renal outcome. So that's why we should protect these outcomes by using the SGLT2 inhibitors, and early diagnosis of CKD is of paramount importance and for preservations of the kidney functions and the cardiovascular status. And we have learned from our speakers as well in the empiric kidney. It showed that there is a risk reductions of the kidney disease progressions by 37%, acute kidney injuries by 23%, and the cardiovascular death or hospitalization for the heart failure by 23%. So the bottom line, SGLT2 inhibitor is the game changer, as it was said by Dr. Khalid. And I like the way you express it, and secure the kidney protections as well. So with this, I would like just to highlight that there is we have a chronic kidney disease integrated program which has been developed by Boehringer, and I think it works. All of us look into these programs. So it's 16 local CME accredited and 8 international CME accredited. And the aim of this program is to boost our clinical competence, screening, diagnosis, and treatment of chronic kidney disease for all the spectrums of the specialty. And it offers clinical simulations, and it gives about more than 20 cases, a real interactive cases that puts all of us in the real world interactive. So it has 4 different modules. Next slide, please. So this is the objective, is to diagnose chronic kidney disease in early stage, and this is actually what we are looking for and aiming to prevent the advance of these cases into the end stage renal disease, and also to bridge the main clinical gap as we have it here in the GCC in chronic kidney disease management, which will primarily patient identifications. Next, please. So as we said, there is a 16 local CME hours and 8 international CME accreditations. Next. And there is 4 modules, and each module consists of 5 different cases. So the first module is CKD as a disease and diagnosis, epidemiology, pathophysiology, etiology, and risk factors, comorbidities, and prognosis. And this was almost going together with the presentation that we had today. Module 2 is the available chronic kidney disease treatment option, and the module 3 was highlighting the side effect and the management of hypoglycemic treatment in type 2 diabetes mellitus, and the 4th module, chronic kidney disease recent guidelines. So I would like to look into this and to explore the wealth of information and the quality of cases that you might encounter in this program. So we have posted the link in the chat box. So please try to look into it and gain your CME hours. So ladies and gentlemen, by closing this session, I would like to thank you all for attendance. And I would like to thank our guest speakers, Dr. Anas Yusuf from Kuwait, Dr. Sultan Al-Bahi from Saudi, and Dr. Khalid Mahmoud from Qatar. And I would like to thank Bringer and Fexes for the organization. And I hope that what we have learned today as a primary care physician will be carried along with us for the next day, tomorrow onwards, to be implemented to safeguard our patients and to screen those people at risk and to prevent the progressions of chronic kidney disease. So thank you for all of you, and I wish you a very fruitful practice, and I wish you a good night. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. يعطيكم العافية دكتور أنس.